Should you consider sleep apnea testing in your patient who doesn't have classic symptoms of sleep apnea? So this question came up recently inside my clinical sleep kit program community on one of our monthly case consultation calls. And it's a common issue because many of us as physicians, healthcare practitioners, we're seeing patients who don't fit the classic picture of sleep apnea, but they very well could have some degree of sleep apnea or sleep disordered breathing. And so how should we proceed with testing in those patients? We're going to talk about that today. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine. This channel is for you, the physician, the health practitioner who is working with patients, and you want to learn more about clinical sleep medicine because most of us get such little training in sleep medicine during medical school and residency. If that sounds like you, subscribe to this channel and then go ahead and get my free melatonin brand guide. So many of our patients are taking melatonin, but quality really matters. So you can get my free melatonin brand guide that you can use in your clinical practice. It's a PDF download. You can get that at intrabalance.com/melatonin. I'll put the link to that in the video description as well. People with sleep apnea don't always present with the classic symptoms, and this is especially true in women, but you can see this in all genders, all ages. People can present with sleep disordered breathing, and it doesn't look like the loud snoring and all of the classic symptoms that we think of. There was a patient I was working with a number of years ago who was struggling with insomnia and sleep maintenance issues. She was tall, thin, in her late 30s, and she'd been prescribed a number of different treatments for insomnia, including Ambien, Trazodone. She'd done CBTI or cognitive behavioral therapy for insomnia. She was also struggling with depression, chronic pain. There's a question of diagnosis of fibromyalgia or chronic fatigue, and she was referred to me for psychiatric evaluation and support. And I was working in an insurance-based psychiatric practice at that time. Even though I'm also a sleep medicine physician, I was working primarily as a psychiatrist, and so she was referred to me for that. But because I'm a sleep doc, I'm always thinking about sleep disorders, including sleep disordered breathing. So I was working with this patient and I suggested to her, you know what, maybe we should get a sleep study. You've never had a sleep study before. You have depression, you have all these aches and pains, there's these insomnia, sleep maintenance issues. I suggested we get her tested for sleep apnea. She wanted to do that through her primary care physician because they were with a large hospital group and it made sense for her to get a referral through her PCP and go that route. She spoke to her PCP about it and they immediately said, nope, you don't need that. You don't have sleep apnea, you're thin, you're athletic, you don't have the classic symptoms. I don't think we need to pursue that testing. And unfortunately, that is a common story. I hear this all the time. Now, I don't want to blame the doctor because we really don't get enough training in this, and especially when it comes to sleep apnea in women, there is such little research around this, and we're really not trained to look out for the signs and symptoms. At the end of the day, we were able to arrange a sleep study for this patient, and lo and behold, it was positive. She was diagnosed with mild obstructive sleep apnea and she got that treated, and many of the symptoms that she was struggling with started to improve. And this of course is concerning because as you can see in a case like this, it leads to issues with misdiagnoses, to patients being placed on incorrect treatments, or delays in the correct diagnosis and management. Females with chronic pain and obstructive sleep apnea have higher levels of pain and higher levels of disability, and they tend to have an overall lower quality of life. Now this patient was premenopausal and she had sleep disordered breathing. By the time women get to menopause, rates of sleep apnea double. So we really need to be thinking about sleep apnea in women who have already gone through menopause. It's thought that maybe about half to maybe even 2/3 of women in menopause have sleep apnea. As we discussed, the classic presentation of someone with sleep apnea is the middle-aged male who's obese, he's got the 17-inch neck, he's got hypertension and daytime hypersomnolence. Most trials on CPAP and interventions have looked at this patient archetype. In addition to that, most of the instruments that we use for self-reported symptoms, such as the Epworth Sleepiness Scale, the Stop-Bang questionnaire, are not validated in women. And moreover, symptoms of hypersomnia, of excessive daytime sleepiness, can look differently in women than they do in men. Most of what we do with regard to diagnostic testing, evaluation, and management of sleep apnea in women is really extrapolated from these studies on men. Now, women are also more likely to go to doctor's appointments alone. They may not have their bed partner there with them who is reporting back on their sleep symptoms that have been observed. And another thing I hear frequently from women is they'll say, my husband has sleep apnea, he snores, he wears a CPAP machine. I don't have any of those symptoms, so I don't think that I have that. But women with sleep apnea are more likely to report that they feel depressed or that they're having trouble sleeping. This could explain why sleep apnea may be overlooked in women and then they instead get diagnosed with depression or insomnia. That leads us to a key feature that's different in women compared to men when it comes to sleep apnea, is that women tend to have more anxiety and depression. They tend to report more symptoms symptoms of insomnia. Women are also more likely to be prescribed antipsychotics, antidepressants, and anxiolytics for these symptoms. On polysomnogram, you'll see that they tend to have a lower AHI overall. Obstructions are usually more partial rather than complete airway blockage, and apnea and hypopnea events are usually shorter than they are in men. Women also tend to have less severe obstructive sleep apnea during REM sleep. Now, this doesn't mean that the long-term consequences are more mild, even if the overall AHI or apnea-hypopnea index is more mild. In fact, studies suggest that mild sleep apnea in women may have more severe cardiovascular and neurocognitive side effects than they do in men. Stay tuned in a few weeks. We're going to have Emma Cooksey on this channel. She is a sleep advocate. She herself was diagnosed with obstructive sleep apnea. She advocates for patients and for women to get diagnosed and treated. You can follow her at Sleep Apnea Stories, and we'll have her on the channel in a few weeks, so I'm really excited about that. If you have any patients in your practice who you think might need to be tested for sleep apnea, let me know in the comments below. Some other key differences in sleep apnea in women include that women usually need lower CPAP pressures, even with the same OSA severity in men. Now, of course, these are all generalizations. I do see women who do need higher CPAP pressures or who actually have more severe OSA during REM sleep. Sleep apnea causes systemic inflammation, and in women, when that sleep apnea is treated, you get faster reversal of that systemic inflammation than you do in men. When should you be considering sleep apnea in women? Because the symptoms are a lot more subtle, they're a lot more nonspecific, you may not be hearing about the loud snoring and the gasping arousals. But some of the clues to look out for are nighttime awakenings, sleep maintenance insomnia, even sleep onset insomnia or early morning awakenings can be a sign. Morning headaches, issues with mood, including problems with focus, memory, attention, irritability, brain fog, anxiety and depression, daytime fatigue and tiredness, waking up to use the bathroom frequently, and restless leg syndrome can all be symptoms of sleep apnea. Now, remember that sleep apnea fluctuates from night to night, so one negative study doesn't rule it out. If your patient comes back and their study was negative, but you're still suspecting that they might have sleep apnea, they still have all of these symptoms, it is worth getting repeat testing. Some labs are now offering multi-night testing, especially with home tests. Some of them do offer up to 3 nights. I've been using Empower Sleep in my practice, and they can do 30 nights or more of testing, which gives you a more longitudinal view of what's going on with their sleep. If you are a primary care doctor or psychiatrist, if you're not seeing the patient specifically for sleep, you may not have time to go into all of these different aspects of sleep. I like to really streamline my clinical practice by making things more efficient. Some ways you can do this are to include rating scales before your visits. You can include the Epworth Sleepiness Scale, the Stop Bang questionnaire, as we discussed. Now, as I mentioned earlier, there are limitations to those, especially in people who don't have that classical picture of sleep apnea. If they don't have a high pre-test probability, these rating scales may not capture the symptoms, but it's a good starting point just to get more data. I also like to include questions in my intake form about sleep. I'll ask those specific questions that I just mentioned, listing out the symptoms of nighttime awakenings, any issues with sleep onset or middle insomnia, early morning awakenings, morning headaches, mood issues, daytime fatigue, nocturnal urinary frequency, restless leg syndrome, and so on. I also build these questions into my H&P template. I do tell patients that, look, I really want to understand what's going on with your sleep and your fatigue, so this might take a couple of sessions for us to really dig into the information and see what's going on, and I might recommend some testing. I also do use a 2-week sleep diary for patients to take home and track, or if they're using a wearable like an Oura Ring or a Fitbit or an Apple Watch, you can also use that data in your practice. These are all things we talk about inside my clinical sleep kit program for clinicians so that we can better support our patients with evidence-based approaches to sleep medicine. If you want more guidance and community around really supporting your patients more effectively with sleep, then go ahead and get on the wait list for the clinical sleep kit or CSK. I hope this information was helpful for you. If it was, please click the like button and share this video with another colleague in your life who could benefit.